Thank you all. Sorry I didn't have my presentation loaded. I just got off the plane from New York, so I didn't have time at the break. What I've been asked to do is give a general overview of the role of biomarkers in screening, diagnosis, and the management of cervical disease. You've had a lot of great lectures by people with huge amount of experience now on the use of HPV DNA testing. And I think it's obvious to everyone at this point, having heard Dr. Schneider's and Kinney and Meyer, that we clearly have a role for HPV in our screening populations. The question with biomarkers, though, is a little different because there are other areas in which it is possible that we are going to be able to use biomarkers other than just as a screening test. So where are the areas where we are seeing clinical need for additional biomarkers? Well, we clearly need them because cytology has a relatively low sensitivity, irrespective of whether liquid-based cytology is utilized. Interpretation of cytology is subjective. Performance varies greatly between laboratories. You can have almost a twofold variation in the performance of cervical cytology in good quality laboratories. There are huge interlaboratory variations. In addition, many studies have shown that HPV testing, when used alone, has a low specificity in women 25 and 40 years of age. So other biomarkers could be used both for primary screening as well as for a triage of high-risk HPV positive women or of cytology positive women. We also have a need for biomarkers for histology. And the reasons here are probably less obvious to you all, who I assume are primarily clinicians. Histopathology is quite subjective, and diagnoses also vary greatly between different pathologists. Something you show me and I call a CIN2 or a CIN3 lesion, you may show to another pathologist and they may call it normal, and vice versa. And as a result of this subjectivity of biopsy interpretation, some women with significant disease are not appropriately triaged or treated, and some women without significant disease undergo unnecessary treatment. So it cuts both ways, false positives and false negatives. In terms of management of patients, these are management with abnormal test results. There are a number of reasons why we need additional biomarkers in this area. First, histopathology is a poor predictor of an individual lesion's natural history. We're going to have a symposium on Wednesday where we talk about the natural history of CIN2. Merely calling a lesion CIN2 does not tell you whether or not that is a lesion which will regress or that is a lesion which progresses. So we need biomarkers to help us in determining which way a CIN2 or a CIN1 lesion is going to go. Secondly, treatment of CIN2-3 has costs and a significant impact on future pregnancies. So clearly, we don't want to be treating every woman with CIN2-3 if we can identify biomarkers which will prevent us from doing treatment and safely allow us not to treat everyone. Optimally, we would like to follow lesions that will regress and reserve treatment for lesions that will progress or persist. So there are three areas where biomarkers are going to be potentially useful: to improve sensitivity and specificity of our screening program for cervical disease, to improve our ability to accurately diagnose and grade cervical lesions, and to identify those lesions that will spontaneously regress without treatment. So what are the molecular markers which are being considered for use? There are really three which are closest to what I would call prime time, most likely in the region where we're going to be using them in the near future. One is a group of immunohistochemical stains. I'm sure all of you have heard about P16 immunostaining. This can be used either alone, it's commercialized as Syntec, or it can be used as a dual stain, which combines both a proliferation marker, which is Ki67, which is a protein which is upregulated when cells are proliferating, as well as P16. So it's a dual staining. Chromosomal amplifications, I think, are quite interesting. 3q26 amplifications. This is a region of the human telomerase gene, and there are now machines which are capable of doing fluorescence in situ hybridization with algorithms which can accurately identify cells which have amplification, and specifically of the 3q26 region. And then there's aberrant methylation of cellular genes, and a variety of loci have been identified for aberrant methylation. It's unclear today whether or not we're going to have to look at multiple genes being aberrantly methylated, or whether at some point we're going to come up with only one or two. And I think that Dr. Schneider's has done a lot of work on this, as have others, and it's still unclear what the best panel is going to be. So that's a little further back. With P16 and Ki67, we have a well-understood molecular pathway. Overexpression of high-risk HPV-E7 oncogenes disrupts the retinoblastoma protein. This regulates cell proliferation. You get unregulated cell proliferation when this occurs, and you also invariably get upregulation of P16 expression in the cells. And P16 is a cellular protein that inhibits cyclin-dependent kinases, and therefore it also plays an important role in cell proliferation. So this is just a pathway. You have a oncogenic transformation by high-risk HPV. You then get release of E2F from the retinoblastoma gene product. You then get overexpression of P16. This is invariably occurring on the pathway to invasive cervical cancer and high-grade CINs. And we can detect this very easily just with immunohistochemical staining. Anything which stains brown has got overexpression of P16. I think my daughter could do this as well as I can do, and she's not a pathologist. And here you can see the top panel is a low-grade CIN. You have strong diffuse staining. The bottom panel is something some pathologists may call metaplasia. Other ones would call it CIN2 or CIN3. But you see it heavily overstains with P16. So I think every pathologist combining the H&E and the P16 would say this is a high-grade lesion, a CIN2-3 lesion. There have been meta-analyses looking at overexpression of P16, and you can see it's very uncommon in normal biopsies. CIN1, about 1/3 of CIN1 lesions will stain with P16. So P16 won't tell you whether or not a lesion is a CIN2 or a CIN1 because it's positive in about 1/3 of CIN1 lesions, but it does tell you whether something is neoplasia or not neoplasia because only 2% of normal will have overexpression. And you can see as you get to CIN2, it's 68%. As you get to CIN3, 88%. And actually, in most of the more recent large studies, we're up to 95% of adjudicated CIN3 lesions will be P16 positive. This is with dual staining. This is being used for cytology. Here you have the brown cytoplasm showing you P16 positivity, and the red nucleus showing you that you have Ki67 positivity. So this is a proliferating cell which is overexpressing P16, and this appears to be highly specific for cervical neoplasia. And what is nice about this is that this can be used on liquid-based cytology specimens. So when Dr. Kinney was speaking about the large number of patients in the Kaiser system who have negative cytology, who are high-risk HPV positive, one of the objectives of doing dual staining on liquid-based cytology is that we may be able to triage those normal cytology high-risk HPV positive patients using a dual stain and therefore be able to identify which women have neoplasia and need colposcopy out of that population. This is a study which directly looked at. It's from Dr. Petrie from Germany. He took women 30 years of age and older who were enrolled in a HPV and cytology co-testing study. There were 425 of these women who had negative cytology, who were high-risk HPV positive. They did dual staining for Ki67 and P16 on the liquid-based cytology specimens, the residual material, And then they correlated the P16 dual staining with histologically diagnosed SIN2+ detected during follow-up. And the numbers are really quite striking, I think. They had 425 women who were cytology negative, high-risk HPV positive, and of those, 1 out of 4, 108 of them were found to be dual stain positive. Of the ones who were dual stain positive, 34, or almost a third of them, had biopsy-confirmed SIN2-3. So 1 out of 3 of the dual stain positives. But look on the other side. We've got 75%, 3/4 of the women being dual stain negative, and there were only 3 cases of high-grade disease when the dual stain negative patients went on to QALFPA. So it was 1 out of 100 versus 1 out of 3. That's quite an enrichment for finding high-grade disease among the dual stain positive versus negative population. 3q26 amplification as a biomarker. It's been known for many years that amplifications of the long arm of chromosome 3 are common in cervical cancers. In fact, some people have done studies. None of these have been huge numbers of cervical cancers, but in some of these studies, we are over 95% of the cancers having amplification of chromosome 3 regions. The amplified loci have been mapped to a specific region on the chromosome, which encodes a human telomerase gene. This encodes a template for telomerase RNA. And telomerase activation has been shown in lots of different studies to be an early event in cervical carcinogenesis. And this is a photograph showing you the amplification. I think you can see it there quite nicely. The red dots, hopefully you can see that in the back, are the number of copies of the Turk probe, and then you have chromosome 3 centromeres, which are shown in green. And with fluorescent in situ hybridization, you can identify over-amplified cells. You can see that the normal, they have 2 copies of the Turk probe, whereas in the SIN2-3 lesions, they have multiple copies in many of the cells. Based on 6,700 samples correlating 3q26 amplification and a final histological diagnosis, this was done with liquid-based cytology specimens, you can see it looks very similar to what we saw with P16 overexpression. 6% of normals, 21% of SIN1 showed overexpression, SIN2 was 69%, and SIN3 is 82%. So a gradient going from no disease up to SIN3 in the percentage of them would show amplification of 3q26 region. This is a study which I'm presenting as a talk later in the week. This is a larger subset of patients. Normal, these were dual negative. They were high-risk HPV negative, and they were cytology. And at the time we put this together, we did not have a single case of amplification of 3q26 in these double negative women. When we went on, we picked up 2 cases, so it's not 100% specific, but it's quite specific. And SIN3, you can see 35 out of the 43 cases showed amplification of the 3q26 region. Finally, let's end up looking at methylation as a biomarker. Promoter hypermethylation of tumor suppressor genes is commonly seen in many human cancers. Typically, what happens when you get promoter hypermethylation, you silence tumor suppressor genes, and hypermethylation is a relatively early event in tumor pathogenesis. And multiple foci of hypermethylation have been studied in cervical neoplasia. This is just one study looking at women who are normal versus cancer, showing methylation of specific loci. These are 2 different loci. And you can see there's a fairly significant difference between the number of cancers which are methylated at these 2 loci versus normals. Methylation is less well developed, I think, at this point than is the chromosomal amplifications of specific regions and of P16, but clearly it's something which a lot of research is being focused on currently as far as getting a new biomarker. So where are we? There are three areas where potentially we can use these biomarkers, improve sensitivity and specificity of our screening programs, improve our ability to accurately diagnose and grade SIN lesions, and identify those SIN lesions that will regress spontaneously without treatment. This is early. I don't think anybody is saying these are ready for prime time and for everyday use, except for the use of P16 on histology. And in the United States, we have recent College of American Pathologists guidelines, which now specifically recommend the use of P16 immunostaining for pathologists in specific settings, such as whenever you're interested in whether or not a lesion is SIN2 versus non-SIN2, you should be doing P16 staining. Thank you very much.